Hello and a very good morning and welcome to you all. This is our inaugural master classes in dermatology Saturday morning live. We could not be more excited to be able to join you all for this, I think, really interesting and educational session. We hope you all will join in, tell your friends. I'm Joe Marola. I'm a dermatologist and rheumatologist at UT Southwestern Medical Center here in sunny Dallas, Texas. And I'm here with my dear friend and colleague, Dr. Alice Gottlieb.
It is a pleasure to be here as part of Saturday Morning Live. It is at least as much of a pleasure to be working with Dr. Marola, who is one of my best friends and also my boss. I'm a professor and director of clinical trials at UT Southwestern Medical Center. I too am a rheumatologist and dermatologist, and you're looking at 2/3 of the rheumatologists, dermatologists in the country right in front of you.
Well, that sounds like it's an end of the year bonus worthy. I like that comment. Thank you, Alice. Just joking. And we're going to turn it over to for an introduction to our incredible guest. We really are opening with a bang here in this Saturday Morning Live session. We have Dr. Brittany Weber. I'll let her introduce herself, and then we'll expand upon just what an amazing, incredible physician and researcher she is, and what incredible impact she's having on our field. But Brittany.
Thank you so much, Joe. And Joe's always far too kind because I am the one that feels honored here to be amongst both Dr. Marola and Dr. Gottlieb, who are world leaders, and really excited that I get to actually work with them on a daily basis now. And so that brings me to the introduction. So I'm Brittany Weber. I'm a cardiodermatologist / rheumatologist. And you say, what is that? So I have a fundamental background in immunology training and have spent my time thinking and treating and researching patients with systemic inflammatory diseases. And I previously started I did my training and started my faculty up at the Brigham and Women's Hospital, where I was running a clinic up there, where I met Joe. But now I have seen the light and moved down to Texas, and just recently, and it's really exciting because we actually have just started not only a brand new cardiorheumatology program, but one of the first cardiodermatology programs in the country. And so that's what I do on a clinical basis. And then the other hat I wear, it's actually a large portion of my hat, is I'm a physician scientist, translational researcher. I trained in cardiac imaging, and I do a lot of thinking about how imaging can be a tool to understand the disease burden in our patients with these conditions.
Amazing, Brittany. And I have to say, as you see us all sitting here or you're listening in, Brittany and I are also going to rub salt in the wound here for Alice. We're sitting in what's supposed to be 82 degrees sunny weather here in Dallas, and I see out of the corner there, Alice has about 2 feet of snow. Alice, we're thinking of you. We're thinking of you. We're sending sunshine your way. So with that, I think we're going to kick off. And Brittany, I'm going to dial us back for a minute and say,
Yeah.
a big question. What? I'm going to say what, which is,
Yeah.
you just said
Yeah.
cardiodermatologist.
Yeah.
I think most people, hopefully
Yeah.
if they were driving while listening, they didn't run off the road.
Yeah.
Like, what the heck is a cardiodermatologist? Can you
Yeah.
talk a little bit about your
I love
program
it.
and what that means?
Yeah. I love it because I get the same thing from cardiologists being like, huh? And it's that huh factor that I think is so important, right? Because it's that huh factor just tells you the awareness that we really need to do. And this is why I feel so passionate about it. And, so a cardioddermatologist, well, I look at rashes, but what do I worry about? I worry about arteries. Or, when I gave a talk just this at the recently in Sarasota, Florida, you see skin plaque, but I see coronary plaque in my eyes. And so, or if you really want another visual, a cardiodermatologist, I just take away your dermatoscope and I put my stethoscope on. But anyway, funny aside is really what is cardiodermatology? Well, this is really, I would argue, a very important emerging field where a cardiodermatologist manages the cardiovascular and the metabolic risk in patients with immune-mediated inflammatory diseases. So what do we think about this? Well, a part of what I've researched a lot intensely is psoriatic disease, but there's also other conditions that I would see in my program, including HS, cutaneous lupus, as well as just medication side effects that have cardiovascular. And then there's emerging other, diseases that were not diseases in dermatology, but cardiovascular risk that are being associated. And so another large part of my clinic is really trying to think through screening, how we can really focus on prevention of risk in our patients and coordination with dermatologists, primary care, as well as subspecialties when there are certain disease manifestations.
That's amazing. And I'll just add also that she does have an official appointment with us in dermatology as well. So she's very much embedded. She's also a cardio-rheumatologist. We'll spare you now, but she sees the breadth of skin and joint inflammatory disease. And I think hopefully over the rest of the morning here, our session this morning, you'll understand what a cardioderm is, and you will wish you had one the way we do. So with that, I'll turn it over to Alice.
Brittany, why should dermatologists and rheumatologists care about cardiovascular risk earlier in the disease and treat more aggressively than we traditionally have?
Yeah, thank you, Allison. This is such a great question, and it really gets back to, what we have learned from the epidemiological data. We know these patients are increased risk, but why we should be thinking about this is because by the time a patient with these conditions would meet, quote, a traditional cardiovascular risk threshold, they have already had years of inflammatory exposure by diseases such as psoriasis. And it's that inflammatory exposure that helps accelerate atherosclerosis, promoting that risk. And so if you think about chronic systemic inflammation, and we know this now in just in the general field of cardiology, it behaves like a risk amplifier. And we also know in our patient populations with these conditions, this has been well studied in terms of the rheumatologic conditions, that our standard cardiovascular risk calculators, they don't adequately estimate risk well. The other thing I think is important as, a dermatologist and a rheumatologist, you guys see your patients frequently and often, and you see them more than sometimes anyone else. And so you're well positioned to be able to catch these early risk factors such as dyslipidemia, insulin resistance, sleep apnea, smoking, all the things that we can be, all working together on as a multidisciplinary collaboration and reducing early on.
So Brittany, can I just to take a deeper dive into that?
Yeah,
So, recently you presented, this really stuck with me, the CV risk calculator piece. So I think there were 2 points
yeah,
I'd love for you to, if you would,
yeah,
for the folks listening. One was the fact that, none of these calculators, or very rarely, do they actually have a button that, that you tick off that says a person has chronic inflammatory disease, increased risk by X. And number two, and this really stuck with me, you recently showed us a patient case and you showed us what their 10-year risk was. But then you
yeah,
said, hold on, what's their lifetime risk? And I'm treating
right.
lifetime risk. Can you maybe take a
Yeah.
double look? That really stuck with me. I thought that was so impactful.
Yeah. And so when we think about these risk calculators, just like you said, Joe, we know that they're not they're going to underestimate risk, which is why our guidelines now appreciate these diseases as risk enhancers. So if a patient is, borderline intermediate, you're not sure if that patient would be eligible. And then they've got, psoriasis, and maybe they have one other risk factor, that pushes me there. But, we're also starting, we should be thinking of as prevention cardiologists is not just a 10-year risk, is lifetime risk. And the new calculator that has been adopted has been the Prevent calculator. And if you haven't heard about it, you will a quick search on the internet, you will can hear all about it. But it's a new calculator that we're incorporating both with our pooled cohort equation that's got some new additions. It adds in socioeconomic variables. It adds in features of the CKM syndrome. But importantly, what else does it do is not only is it an ASCVD and it's got a new heart failure, but it calculates at a younger age, which is important in our disease conditions, and it calculates both 10-year and lifetime risk. And when I see, when I have a patient with psoriasis referred to me, and that's 32, and they've got these cardiometabolic risk factors, their 10-year risk may be low, but their lifetime risk is not low, right? And I'm trying to prevent that heart attack when they're 65, and I really just discuss with the patient that and try to kind of emphasize that to them, because I think that helps them feel motivated to kind of lower their risk now.
Yeah. No, that's brilliant. And if I remember right, I mean, most of the historic calculators, was it below 40? Don't even
Exactly,
try? Is that right?
exactly. So the pooled cohort equation, it actually, it was, it's not even calibrated essentially for, but that being said, if I have a patient that's like 38 in my clinic, I would still kind of put them in as 40. But technically, if you're going by how those risk calculators were made, they were not even made for people in the young. And that is an important point you just made, Joe, because I also think a lot about the young, and we know risk begins in the young, and we don't have adequate tools to assess risk in the young because they're never going to have that risk, of over the next couple of years based on these scores. And this is really where I think imaging can play a role, and along with other biomarkers in defining higher risk patients earlier on.
Well, having heard your lectures in the past, I have no doubt folks are going to have to buckle up because there'll be lots of imaging discussion coming soon. I have no doubt. So,
Well, I could talk for hours about this topic, but I don't want to bore everyone on here. So I want to kind of ask you and Alice a question. For maybe start out with Joe first. Could you tell me how both of you are screening cardiovascular and metabolic syndrome in your clinics right now?
yeah, I'm happy to start. Alice and I have this conversation all the time, and I think I like to draw some parallels to what we do with PSA, what we've been saying for
Yeah,
PSA for years, which is I think we absolutely have to own the screening piece, and then the question of whether we decide to own the management or not, I think is a little bit practice specific, person specific, depending on bandwidth, support, et cetera, et cetera. I think. Well, I'd be happy to hear other
yeah,
thoughts. I mean, I certainly am, checking lipids. I think I check labs anyway on so many of our patients. To be honest, many of our newer targeted biologics don't necessarily need a lot of screening, but I think it's good practice to have some baseline labs to know who we're pouring these lovely drugs into at baseline, for many reasons, and medical legally included. I think it's good to have some baseline knowledge of the person that you're conversing with. But I do check lipids, and then I'm going to turn it over to Alice because I'll tell you I think the screening piece is I can get my head around basic screening.
yeah,
Smoking, lipids, and hypertension. But I'll be honest, I'm biased, and because I have a cardiodermatologist at my
yeah.
fingers. I mean, I'm in a very resource-rich environment where I have that ability to refer, to have a conversation, pick up a phone. I have some extra time in clinic. That's not the case for everyone. We're very sensitive to that. So I want to
Yeah.
also ask Alice, who's worked in a variety of scenarios, how she's addressed that issue.
So by way of disclosure, I've worked most of my career with poor and Medicare patients. And I think that the important thing is to one way or another get them screened. I give you scenarios where my patients are in a managed care setting where they have to where much of this has to be managed by primary care before they're even allowed to see a cardiologist. So in that case, it's a different approach than if I'm sitting in a private practice at UT Southwestern, where I have the best of the best at my fingertips. So I think you have to the most important thing is that I tell this to my patients and the residents know. I tell them, I'm going to make you beautiful or handsome on the outside, and I want your insides to look as beautiful or handsome as that. And to that extent, I'm going to make sure that you have a primary care physician. I'm going to, if you don't have one, I will set up the referral. And I'm going to drip, drip, drip and torture you each time and say, did you see your primary care doctor? Do you have any problems there? And so that is something that almost anybody can get. Obviously, as Joe does, most of our blood work does include
Yeah.
a lipid panel. It also we look at our patients. If they're overweight, you can see that they
Yeah.
usually get a blood pressure taken. We ask about diabetes, and we usually have a hemoglobin A1C. So we kind of do that screening with almost all patients, independent of risk factors. I certainly in a setting where I have residents who've had 1 year of medicine training, I don't feel comfortable, frankly, with them managing
Yeah.
statins. I don't feel certainly not issues like using the injectable
Yeah.
drugs against LDLs. I don't think they really feel competent about it. That if they get one elevation in CPK, they're going to stop it. I mean, and so and I so I don't feel comfortable doing that. I think it is the job of primary care. It's our job to make sure that they see primary care and that primary cares are taking care of it. And if it's more advanced, then almost any insurance will let them refer to a cardiologist.
Exactly.
They might
Yeah.
not be as good as you, but there's certainly plenty of good cardiologists in the United States.
Yeah.
And I mean, just to expand on that, by the way, I have no trouble starting statins. I start
Yeah.
statins on my patients. I think we shouldn't be afraid to, but again,
Yeah.
I am very sensitive to the
Yeah.
practice pressures that are, that exist. And so as long as someone's doing it on behalf of
Yeah.
people referring, I agree with that. I've also started GLP-1s now, and I'm comfortable with that among some
Yeah.
other things. Now, the question I have for you though is when is it a referral to primary care? When is it a referral straight to the cardiologist, in your opinion, preventive cardiologist or otherwise? Is there a certain risk, is there a certain ASCVD risk score, or is there a certain, symptom profile of patient where you say, hey, PCP is good, but actually I want them in my office?
Yeah.
Is there a threshold you would think about?
Yeah, it's really a great question, and I will say that if I had the bandwidth as Joe and Alice knows, I would see everybody, right? Because this is my passion. I feel like everyone would deserve a cardiodermatologist or rheumatologist risk assessment, and I love to see any patient, even if I'm really discussing their risk over their lifetime and they're not those high risk patients. But practically speaking, we know. And in general, for even just the cardiovascular community, we cannot see every patient. So I do agree completely agree, Alice, that the primary care provider, is the provider that's often that is managing the blood pressure, that is managing the lipids, and so the patients that of course I'm gonna have uniquenesses with my own specialty clinic, but people with so say I can give a couple of scenarios. There's not a certain risk score I would use, Joe, because we know that these risk calculators are kind of we've already talked about how they were nuanced, but once there's established disease, that's clear, right? And you may say, well, wouldn't they already have a cardiologist, established disease? No, not necessarily, right? What if they had an imaging test that shows they've got atherosclerosis, but they were actually, they never connected with a cardiologist, right? Clear, we'll talk, I'm sure we may get into some of my imaging based research, but that's a patient that, I do want to see. Statin, so say a PCP does start a statin, or the dermatologist is able to start a statin intolerance, statin side effects. It's tough problems. These are things that like I have training in, I deal with on a daily basis. It's tough, and it's things that that I feel empowered to handle. We've got multiple tools in our toolbox to keep people on lipid lowering therapy when they have intolerance. So I really want to emphasize that point. And if it's not statin, I've got multiple ways I try to keep people on statins first, especially with insurance costs based on what people can escalate to. But if not, we've got a bunch of great options. PCSK9, dramatic cardiovascular risk reductions, much easier to get access to these days. And we're now even shifting this into the primary care. But these are also indications. Another indication is I'm not I don't think I would expect every dermatology clinic to be screening lipoprotein A. We are hoping to get that communication out there
Yeah, I
for,
just checked it on
yeah.
someone yesterday. All right. So
Good.
I
Thank
learned
you.
from the best. I
Yes,
learned from the best.
I love that because it is in cardiology guidelines that everyone deserves a one-time risk assessment. And when I go to the standard, American AC or American Heart or ACC meetings, we're now screening for just anybody like us that walks through CRPs and lipoprotein A's because I've had mine checked, and it is a one-time. It's not like lipids. It is a lipid molecule, but it's more genetically determined. So we don't need to be checking a lipoprotein A every year in a patient, but you should have a screening because it is strongly associated with risk. The challenges with patients like this, though, is that we don't have specific lipoprotein A lowering therapies yet. I will still use these other agents to lower risk, but say a patient has a very high lipoprotein A, that's an appropriate referral to my clinic where I can be discussing what we can do right now as we kind of await the further data. So those are just a few scenarios.
Amazing. What one comment, and then I'm curious to hear Alice's comment on another point you raised. But I just want science fiction to me. I learned about this fairly recently. I think most of us are learning about PCSK9
Yeah.
inhibitors, but I understand there's like an siRNA version that's like is it once a year or twice a year?
Yeah.
That is
So there,
absolute science fiction to me. Tell us how
we have newer agents. We have inclisiran now. It is certainly this is not a drug that we can it does take time to get access to these drugs. These are ones just to be honest with you, I've used in select scenarios because I do get to work in a prevention clinic. But certainly, and we're going to be seeing more and more of types of therapies that target this technology. But right now, I still would say that access is even at top institutions still takes some time. And so certainly for the broad scale populations, these will not be the main things we're using, but for people with indications or certain high genetic high lipid disorders or just failure to tolerate at the highest risk, these are eligible for them.
I just think it's incredible. I want to
Yeah.
ask Alice and maybe you via Alice, CRPs, I mean, so non-specific. Do you check CRPs? How do you interpret them? And I'm curious to hear how Brittany interprets them.
Yeah.
So I just read an article in the New England Journal on the genetic basis for cardiovascular disease. And that article actually came out against doing CRPs. It came out with all the other stuff that we talked about, but that was actually said it is not necessary. Of course, we have been doing it. I personally do not do CRPs in a psoriasis patient routinely maybe in a psoriatic arthritis patient for other reasons. But I don't routinely do CRPs unless I have a reason to. And this article actually said that it does not need to be done. But I gather there's a bunch of controversy in this field. But this article is actually, we're doing it in Journal Club next month. I'm putting that as one of
I'd
my
love to hear Brittany's take on that. I mean, again, Alice alluded to this, and from a PSA standpoint, prediction
Yeah,
for prognosis for joint
right.
damage, et cetera, there's some value there. I think it was our both former colleague and a dear friend of mine, Pradeep Natarajan, I think, who was part of that article. But I'd love to add, Brittany, what, I
Yeah.
mean, tell us your thoughts. Yeah.
Yeah, big topic, and you guys probably don't have 2 hours for me to pontificate because I do think about CRP a lot. I do check it, and so a few things, but I also understand the caveats, and particularly caveats in patients with inflammatory diseases. So that's important to remember. So what do we know about CRP? Well, we have strong prognostic data, right? So it is highly prognostic. I mean, this is fundamental work from Dr. Paul Ridker, many others, including, New England Journal of Medicine papers, as well as, a recent one that demonstrated, a one-time check of CRP could predict 30-year outcomes in primary prevention in women. And so, I have thought a lot about CRP, and there is emphasis, including in guidelines, to be checking CRP. It's a risk enhancer in our guidelines, and there was a recent ACC statement addressing inflammation where it is recommended. So thinking of all these nuances, but going back to CRP, we also all know here, also as immunologists, that it is a non-specific biomarker, right? It is downstream, and importantly, it's downstream of what we believe to be the causal pathway in atherogenesis, which is it may not be the primary mediator in everybody, but IL-6, at least in the general cardiovascular patient. And IL-6 is actually causal in terms of genetic studies, where we know CRP, just like Alice is alluding to, is not causal, but it's a prognostic feature. And so what do I do? So practicalities. Okay, so we know, as you just alluded to, also that in psoriasis, we wouldn't be just repeat checking CRPs to guide skin responses, right? You guys would use your PASI scores and your other data. We certainly it certainly has more role in arthritic involvement, as Joe mentioned. What do I check in my clinic as a cardiologist? I check it when a patient is stable and they're getting their lipid assessment, and I'm doing a cardiovascular risk assessment, because we know it's a risk enhancer, right? So I do think it's important to identify a patient with psoriasis, even if their skin's controlled, that has elevated levels of systemic inflammation. How we target that systemic inflammation is what we have to figure out as a field, right? So what are things we know will elevate CRP? Obesity, right? Strong link with obesity, right? I clearly see elevated CRPs in relationship to obesity, and the GLP-1s also lower, if you look at the select data, lower CRP independent also of actually just losing weight too. So there's multiple ways that I can get at controlling systemic inflammation without adding another drug. But I do think I do check it in those scenarios.
Excellent. All right, so this is going to be a group event. So, we are all about collaboration, collaborative clinics, joint clinics. I'm going to ask for Alice's input and then for your input. So,
Yeah.
these collaborations between derm and rheum have been going on for many years, formally or informally. And now we have the cardiology derm and cardiology rheum connection. What should these look like, in real life? And, how are we informing each other's practice? I'm going to start with Alice to comment a little bit on maybe the derm rheum interface, and then Brittany for the cardioderm cardio rheum interface.
Well, I'm going to talk about something that's relevant to both. And we know that dermatologists are underdiagnosing psoriatic arthritis, and there are many reasons which I won't go into now. So we at Mount Sinai, in collaboration with Joe, we actually took it out of the hand of the dermatologist and had the patients do the work. And so we put into the system a screening tool called the PEST, which the patient does. And if they are positive for, maybe you could have psoriatic arthritis, they're given a simple questionnaire, which is a target to treat to. And that is done by the patient. And we programmed into the medical record that if the PSA test is suspicious and they are not in target range as by the symptoms and impact questionnaire given to the patient, there's a button that the doctor presses or the PA presses, and it says refer to rheumatology. And the rheumatologist is a click away. And even when you take those patients, you pick up a pretty high percentage of undiagnosed psoriatic arthritis. Has the doctor or PA in derm done any of the work? No, the patient did the work, and we put the EMR to work for us. Similarly, I believe that I think Joe and Brittany are the drivers, but I'm helping with that too, is to try to develop something that is patient and image focused, that basically the doctor doesn't have to do the thinking in a certain sense or finding the cardiologist. And these studies are in progress, and I'm going to let Brittany talk about it as much as she wants to, but there may be ways where you can look at the EMR and the past and see ominous things for the future cardiac wise, and make sure that the cardiologist, if not maybe as good as Brittany, but a cardiologist sees the patient and tries to change the natural history of the process.
Yeah, I love this question, as you both know, and so because I think a lot about multidisciplinary care models, and I feel so fortunate that we get to have this. You guys let me into dermatology, and that we can really hope to at least empower this to grow, to grow across. But I also recognize that. That not everyone's got such a setup. So when we think about what is good collaboration, well, I think about this is that good collaboration in one sense is quote boring. And what do I mean by boring? Boring is actually, in a way, it's kind of like the best way, right? So when you think about a good collaboration, you think about something that is predictable, repeatable, and it is something that integrates into the daily workflow, right? Like, I completely recognize how busy a dermatologist is in clinic and how many patients are seen in the day, and it's got to be something that can work, right? We can't. You guys know the sky's the limit for me, but I'm also kind of like, I know I can't have my dream of everything. So what can we do? Practicality, and so a few points is that. First, just having shared language, shared thresholds. And these are things that I've had the opportunity to work on. Like, we have a great PPAC-Man society. We had a recent guidance document where we have like some basic recommendations that are not meant to be, 20 pages that you're never going to be able to read, but they're just a 2-page document or what are some kind of practical languages a dermatologist and a PCP can use for cardiovascular risk. And so I think more efforts like that and shared language models is important. I also think, which is what we've talked around into, and we've also alluded to, sensitivity of how busy one clinic is. And what does that mean? Well, that means clear ownership, right? I don't expect a dermatologist to be prescribing all these therapies. I love that I have people like the two of you that will prescribe statins, and I've had rheumatologists even ordering calcium scores. I love that, but that's not like a requirement, right? So even just defining, if the rheumatologist is screening, flagging risk, referring, PCP is managing the risk, these risk factors with a referral pattern. I think that's really important, especially in areas where we don't have a program just like ours, where there's just kind of, who is doing what is at least kind of defined. And then I would say the kind of last thing I want to talk about that you mentioned, Alice, is really how we can move the needle. And so I think a lot about how to move the needle. And I think that moving the needle, I believe at least, is going to require imaging, because we're going to have to, we want to see the disease. And I gave a debate on this at American Heart Association, and I use derm as an analogy. Like, you guys, you see the disease, right? You see the joints, you see the skin, you get biologics. Cardiologists, like, how do we see disease, right? We see disease when we take the plaque is in your arteries, and so we can see and visualize the disease from a prevention standpoint with imaging. And I think that is very powerful also for the patient. And so if if we know we can't just, especially with access, we can't just literally mass screen the population or patients with psoriasis, then what could we use as innovative tools into workflows? And this is something that we're working on at UT Southwestern, and that I feel very passionate about. Is I did a study back at Brigham and Women's where we actually asked how can we use like AI technologies and identify risk that's just already in the medical record, right? We're not spending extra money. A patient's not getting an extra test, but many patients get CT scans. You walk into the ED, you have a pneumonia, you get a CT scan. You've got, rheumatoid arthritis, you're getting a scan for ILD screening. That just sits in the data record. It wasn't ordered for a cardiac risk assessment, but the data is there. They may actually have risk and burden. And so we did a study at the Brigham where we actually used a CAC AI algorithm and we identified plaque. And then we asked, what was the prevalence and prognosis? And not surprisingly, just like it is in the normal population, it was prognostic and it was also really prevalent. So I'm gonna get to the point here, I promise, is that what I would like to do with this concept I just told you is use innovation at systems like ours where we can have something like best practice alerts where we can flag patients that are seen in dermatology clinic that may have already have this data just sitting in the record. No one's even looked at it. It's not being treated. And then when you asked me first on in the beginning, who do you want to see? That's a patient I want to see, right? That's a psoriasis patient that's got disease that's not even recognized. And so that is a best practice kind of concept where the dermatologist just sees it and just has to click. And I think that areas like that can really enable prevention.
I love that. And just for the audience too, CAC AI is the calcium artery
Yeah.
calcium
Sorry.
score. So just we all have our own lingo. So
And I
that's
want,
brilliant. And
I want to,
You say aisle 23 to a cardiologist, they're like,
I want to point out that at least in every place I've been, insurance doesn't cover it, but it's worth the $100 you pay to get a
yeah,
coronary artery cath. It's well worth the money. It's
yeah,
less than the price of two people to go out to dinner. It's
yeah,
just
yeah.
worth it.
Yeah, and often you can fight. I fought multiple times for these, and hopefully the coverage will change. But just like Alice's point, they are inexpensive, and another thing that you can talk to your patients about too. That is an assessment is sometimes even ordering it as a non-cardiac scan, such as for lung cancer screening is often covered. You can get the data as long as you talk to your team at your own institution. So there's multiple ways around this, and I'm always happy to answer questions that come up on this.
that's brilliant.
Right. Are we talking about screening? So what are the current and future image-based screening modalities, and what is the availability in the community versus the advanced centers?
Yeah. Boy, you guys are hitting all the questions I could just go to town on, and I know we're almost out of time, but quickly because I think so much about imaging. It depends what your imaging risk of. So one, I've there's a JACC scientific statement, so a cardiovascular journal where we put kind of recommendations and thoughts out there of screening cardiovascular disease within patients with inflammatory diseases. So we go through the different modalities. And it's important to remember, if we're screening for myocardial, echo is always going to be first line. It's going to be available at any standard medical center. You don't have to be at an advanced center to get something like an echo, but most commonly what we're talking about here today is atherosclerosis screening. So a calcium score, what I would say is the most widely available affordable, easy to implement tests that we just talked about. So I won't go belabor that. And that should be available at every institution. But other modalities that would be available that I think we should be keeping our eye out for the future is when we should be escalating to coronary CT. This is a class 1 recommendation now in our chest pain guidelines for as a risk assessment. People often don't realize how much data you can get out of coronary CTs. If it was me, my dream is that this would be the test for the future for screening because it detects non-calcified plaque and calcified plaque. It actually sees the vessels. You don't actually need to go to the cath lab. You get that data. We can also get physiology. We can get metrics of inflammation of the arterial wall that we have shown as risk. And importantly, it's, low radiation. But can I say today in 2026 that we can screen everybody with a coronary CT? The answer is no, right? But when you said where do I think we're going, that is areas I think are the future, but we're certainly not there yet. I do use it in people with symptoms or if there's a very high risk indication that I can justify when I order it now. Other areas of imaging that I want at least this community to have at least heard about. I don't ever expect a dermatologist to have ordered this or even know about it. But if you're having patients with symptoms, and that's a reason to refer to somebody like a cardiologist. And for disease assessments like microvascular dysfunction, so disease of the small vessels, inflammation around the heart, inflammation of the heart muscle. Patients with our conditions can get these. They're just not as common. Those are areas where I'll use things like cardiac MRI, and I'll use areas like PET scans. But again, those are not going to be the things that we're talking about for the masses.
Amazing, Brittany. So I think we're just about at time. We covered a huge amount. Maybe I'll throw in a quick summary and we'll say thank you. But we covered a little bit about making sure that we own the screening of our cardiovascular risk for our patients with inflammatory skin disease, psoriasis, among others. We talked a little bit about risk assessment and referral as appropriate. Brittany mentioned an easy management algorithm that she published. I do want to remind folks, if you want to find those, they are posted at the Pacman website, ppacman.org. Feel free to take a look at that. And I think hopefully you're all convinced, as Alice and I have been, that cardioderm is a thing. And Brittany's bringing it to the United States and outside of our borders. We like to claim her as the first official cardiodermatologist. I know some people are claiming cardio which you are also in that stratified group, but we will.
He's double boarded.
You are, yes.
You guys are the double boarded, triple boarded.
So listen, with that, it was just, well, thank you for your attention and tuning into this inaugural Master Classes Saturday Morning Live. I'm Joe Marola.
I'm Alice Gottlieb.
And we
Brittany
are,
Weber.
All right, we're thrilled to bring you this and hopefully more to come. Brittany, can we have you back?
I would love to.
Awesome.
Please invite me.
All right. Thank you all.
Bye, everyone.